because this is sort of an unprecedented story where the premiers say we're going to endorse guidelines. You know, what's the real possibility here? You've got potentially narrowing down to a small number of guidelines from the entire cardiovascular community. Can we do something with this? How would Tom pick this up? And I'm going to come back to him in a minute.
Yeah, so we were joking around already this morning. Okay. You see, because it's a nice thing that the premiers now have pressure to actually announce something, you know, in 2 to 3 years. That you know, there's some follow-up to all this, and so a number of provinces are actually very motivated in this. And so I think what we want to do is, in fact, roll out a number of the tools. And the question is where, you know, there may be different opportunities in different provincial environments. You know, how we can do this. So Ontario is very interested in electronic health record implementation. You know, when talking about Alberta, is their chronic disease strategy, and this is definitely will involve the primary care, you know, sort of a community in which we talk about very much. And so we want to actually start out with by moving some process indicators. You know, so we're developing quality outcome indicators in which we can track. But of course, you know, down the road, what we would really want to do is actually see that impact on more hard endpoints like you know, hospital complication rates, you know, patient being admitted to a hospital, and those type of indicators.
Thank you. Tom, I mean, is it possible to have a kind of a guidance document that is not contextualized, or is it agreed to by people across the country that would have some value as you roll out your clinical networks?
Well, at one level, you could say that top-down clinical practice guidelines are really, truly wrong-headed. I don't see that in Sea Change. I think this has really been clinicians and researchers getting together to synthesize a huge volume of content that's been developed over the last really 25 years and distill it down into something we can do something about. But even so, now what can we actually do with these many recommendations? Whatever we do, it needs to be visible, it needs to be doable, and the public has got to get it. So I think the kinds of things that we might cherry pick out of here that give those kind of characteristics. We're keen on enhancing blood pressure monitoring by pharmacists when people walk into their drugstores and get their prescriptions, kind of thing. We think we want to start adopting a few healthy organizations in the province that actually take on Sea Change as a corporate initiative. One of the big oil companies, and maybe even Alberta Health Services could become a heart-healthy organization, stuff of that sort. So we need to pick away at the details. We now got the structure, we got motivated clinicians, we got the incentive programs in place, so we need this type of material actually to work with.
Thank you. Carol, cancer is a little different. Do you want to comment on the idea of trying to get to common guidance or finding some way of moving to common standards in the way care is practiced?
You mean on a national basis?
Yeah.
Yeah. Well, I think that this is already happening. I think that historically, because cancer was well organized within each province, several provinces developed their own guidelines processes or their review of evidence to develop practice guidelines. And they didn't always actually match up from province to province. But I think there have been a couple of things that have happened recently that have led to a big change. The first is the National Drug Review Program, where the basis of this is now a national review of the clinical evidence. And it's the review of the evidence and the health technology assessment that then results in a recommendation that should stand across the country. Now, those are early days, but I think there's a signal of people recognizing that the evidence is the evidence, and while the application of it might need to be contextualized, the actual analysis of the evidence and the recommendation should be pretty uniform across the country.
Can I just make a comment to that, Terry? Mm-hmm. You know, the cancer world has been organized for a long time, as has been said. But a lot of the organization is about cancer chemotherapy protocols and radiotherapy protocols. So the kinds of things we are doing in cancer is not focused on stuff like that, but more the models of care associated with cancer. Right. You know, most cancer surgery is done by general surgeons. As soon as you cross that divide, you get into all kinds of complexities and trade-offs, and you know all about that, right? So the time it takes from the point that you first notice an abnormality on your chest x-ray or a cough with a little hemoptysis till the time you get an actual diagnosis and treatment in Alberta is too long. So that's one of the things we're focusing on now, trying to get the time from the first diagnosis to definitive therapy down to, really a matter of days and weeks from what it has been in months. Or the prostate cancer thing and all of the fussing about PSA testing. What's the role of PSA testing? How frequently should do it after you've been diagnosed as having real prostate cancer? Because that test is out of control on that end too, not just the front end. So the cancer world, if we can't be successful in the cancer world, we can't be successful anywhere.
Thank you. Questions? Shalom, you have the first response here.
I've been listening to a lot of this, and it's really interesting. It's interesting, especially in the light of what the last speaker said. I mean, the kind of description that he had of neonatal care, and how actual practice can make a big difference to how you think about things. I think that one of the things that's happened in the Patients Association is that we've been given lots of sets of guidelines and plans to look at and to see whether or not and to what extent they're actually patient-centered. And largely when guidelines or pathways or even networks are created by providers alone without any patient input, there are lots of aspects of the patient experience that are just excluded, just aren't thought about. And it's not a matter of ill will. It's a matter of not having people there who can sort of present that side of things. So you have, and much of the conference today has had small aspects of that, where we go one way and we say patients really have to be involved and things have to be patient-centered. We want them to be patient-centered. And yet the actual patient being there and being a participant in the development of the guideline or the development of the pathway, or being able to even look at the pathway or the guideline or the network and think about it from the patient perspective, really is only beginning to happen. And I would urge you to recognize that and to begin the process of including more patients in the processes that you're engaged in so that you get the actual patient perspective and the patient view of many of the things that you're trying to do. I noticed that in the cancer care example, the pathway that's being developed that can be understood by patients is very difficult to do and will take some effort. And it looks like it's not even clear that it's going to be able to be done. So I say, good on you that you're trying, but there's a lot more effort that has to be made.
So put the patients at the table when the pathways are being developed and implemented is a key part of that without any doubt whatsoever.
For C-change implementation, working with, for example, Heart and Stroke Foundation, many of the volunteer-driven organizations, in which they have direct access to the patient population to provide feedback in terms of what tools work, what tools don't work.
Heart and Stroke sends their guidelines to us to review, and they are not very patient-centered by and large. So a lot of the stuff that's done is done by experts, even inside some of the sickness organizations, and that should be known as well.
For the people in New Zealand that have had a lot of experience with this, we've partnered with them, and their approach to the dissemination of guidelines is use every mechanism known to man and beast, and make sure that there's always a patient translation type version. So our approach to that is going to be all clinical care pathways will have a patient care pathway that aligns to it and is in essence a takeoff of that is easier to read and understand, and those will all be available on HealthLink. So the call-up line that you have after hours for getting physicians will all have the patient care pathways available to them so they can phone up and find out what their pathway is.
We have one or two here. Can I take both of them in a row and we'll ask the panel to respond? Marie-Dominique and Ingrid.
Take a microphone. Excuse me. So I'd like just to share a few thoughts and maybe some concerns, but I certainly don't want to appear negative. And I'm going to be the primary care advocate here. And what I'm struck by, I understand very well the need for those pathways, but to me it's a little bit back to the disease management approach. And I just want, because I was asked about how can we really have this primary care system going on. And I think that what is really the characteristic of primary care, and primary care providers, be them physicians, nurses, is that we are condition neutral professionals. And when we try to interact, certainly, with secondary care, we actually meet with those disease-specific or disease pathways. So, well, I recognize very well the need to really be well organized. And if I was a patient, I would be so happy to make sure that if I have a lung cancer, they will have a good lung pathway. Now, this is not being negative, but I think it is just to sensibilize all of you that if we have to articulate between primary care and also for those programs, so to think of the fact that the comprehensiveness, multimorbidity is really what's the approach and the condition-neutral approach for primary care. And I know certainly in the province of Quebec, in the Centre de Santé et Services Sociaux, in the CLSCs, you know the acronym, we are working more and more with professionals who actually are totally condition, I would say, free, and bring their expertise, our nurses and from all professions. So it's just a plea of thinking also of this kind of condition multimorbidity approach for the primary care when we try to work together. Thank you very much.
Thank you, Marie-Dominique. Go ahead, Ingrid, and we'll just have the panel respond.
I wonder if you'd comment a bit about how you communicate uncertainty around the evidence to both the providers and the patients. So in some areas you may have no data on frail older patients. For the risk of some drugs, it might be only a small sample of highly select patients. And so as I watch the Institute of Medicine reports, they're trying to think about how uncertainty around the evidence is better communicated to both patients and providers. So can you comment on how that will work in your guidelines?
Carol?
I could start with that. Maybe I could comment on just on the first point, which I think is really, really important, and the issue of how to integrate very complex disease-specific guidelines and make them work within a primary care provider's environment which has to be condition neutral. And we're certainly experiencing that with the pilot study of our electronic pathway solution, where it works really well for the nurse navigator, for the diagnostic assessment program. It works really well for the patient, whose main concern at that point is, do I have lung cancer? It's the family doctor who has to integrate it into the office setting. And I think that's going to be an ongoing challenge. But just to recognize that we've certainly flagged that. On the issue of the communication of uncertainty, there are many areas where there is either uncertainty or there are choices that need to be understood within the context of the values of the individual. And the vision that we have is that in the pathway, when there are specific areas where there is uncertainty, we just be explicit and state that, but try to give a little bit of a detail of why there is uncertainty. And where possible, develop decision support tools to enable patients and their practitioners to work together to try to come to the right decision for that individual patient that's consistent with their values. So that's the desired end state. I wouldn't like to suggest that we're there right now, but certainly there are decision support tools all along the way. There's lots of them available in cancer that could be embedded in a disease pathway.
Tom?
But let me also state the obvious. When there is uncertainty, sometimes you actually do have to do some more research. And so in that regard, we have a number of examples like that where we're working with Alberta government and Minister Horn's department. For instance, we're going to be introducing insulin pumps as a publicly funded service in Alberta in the near future. It's a decision that's been made, and the question is, how are we going to do it? Who should get them?
Right.
On what terms and conditions? And then who should keep them after some requisite period of time? Yeah, there is literature out there, but not all the kind of contextually important things that we need, particularly about continuation criteria. So what we're going to do in that regard is we're going to let that technology out of the bottle with access to it with evidence development and clear measures over the period of time. So we're not sitting here a year from now having introduced the pumps and not knowing what the hell we've accomplished as a consequence. So in the face of uncertainty, you had to be honest. But you sometimes also had to go and relieve yourself of the uncertainty.
Thank you. I'm going to ask you to thank our panel. They've been terrifically careful at keeping to time and very thoughtful.